All right, welcome everyone. Thank you for joining us for today's webinar. My name is Donna Chow, and I'm your host and moderator for today's eLotus webinar. eLotus is the leading provider of continuing education for acupuncturists. Wow, I can't believe it's almost April now, as time sure has flown by. Today, we have 3 groups joining us. Today, our first group is our Watch It Free group, who used a coupon code to access today's webinar for free. The video replay and CEUs are not available for you, but you can upgrade to our second group, which is our paid group. Paid attendees, you will be able to enjoy today's webinar and watch it as many times as you like for the next month and earn CEUs. And finally, if you want to upgrade to our ultimate and full access, it's our third group. Our third group is our Gold Pass members. I'll go into more detail later today, but our Gold Pass members have access to live webinars and distant learning courses for the duration of their membership. All right, so today's webinar is the top 12 trigger point patterns, their diagnosis and treatment in acupuncture, presented by Michael Young. Before we begin, let's do a quick housekeeping. Today's webinar will be from 9 a.m. to 6 p.m. and we'll have 4 breaks, 2 breaks in the afternoon and 2 in the morning. If you have not already, please get your copy of the lecture notes from the Blue Course Access page in your account. If you want to join the chat, please do so right now by setting your chat preference to everyone so that everyone can see what you're typing. You'll have to do this manually because the default setting allows only the speaker and the staffs to see what you're writing. If you have any questions during the presentation, please type them into the question box in your Zoom control panel. If there is time during the presentation, the speaker will answer them. The quiz and the video replay will both be available tomorrow afternoon, and you'll receive an email notification from me when they are both ready. Okay, so let's get started with today's webinar and welcome Michael Young, who is a Colorado licensed acupuncturist who has been practicing since 1990. Michael has studied acupuncture with prominent practitioners such as Dr. Koji Mura in Osaka, Japan, and Dr. Misha Cohen and Dr. Mikishima. Doctors Misha Cohen and Mikishima are both eLotus speakers. So if you are interested in furthering your education with these master acupuncturists, I recommend the Gold Pass membership, which allows you to see all their courses for free, as well as receive unlimited CEUs from our speakers from the past 20 years and free herbs. Currently, Michael teaches trigger points at Southwest Acupuncture College in Boulder, Colorado, and it's such an honor to have him here with us today. Okay, Michael, please take over now and share your PowerPoint.
Okay, thank you, and thanks everyone for attending, and thanks to Donna and eLotus staff for making this possible. And so I'm going to start with the slides, and if that doesn't work, let me know, please. There's contact information. So my history with trigger points, I went to
Michael?
College. Yes.
I think your PowerPoint not sharing.
It's not sharing. Okay,
Yeah.
Let me go back. Thank you. Is that working?
Yep, perfect.
Okay, thanks for letting me know. Cool. All right. So I went to the American College in San Francisco, graduated in 1990. At that time, they were a good herb school. Acupuncture was not taken that seriously. Then I stayed in San Francisco for 3 years, and came to a clinic in Boulder, Colorado, where we treated about 70% car accident people. And there was a body worker there who encouraged me to start studying trigger points, and I did, and I found them really helpful, and so I still use them, and several years later, and so in the course description, there's over 200 skeletal muscles in the body that can manifest with trigger points. But in clinical practice, about 90% of the time or more, we see the same trigger points over and over. So this course will focus on the basics of how a trigger point is created and perpetuated and treated. And Travell's books describe trigger point patterns in over 100 skeletal muscles. And despite this, patients come in with the same ones over and over. So I want to cover the basics of how to, what happens with a trigger point and how to diagnose it and how to treat it. And so that way, if you get some, not as common trigger point, maybe somebody comes in with a trigger point that's once every 10 years, you see, you know the basics, thought behind how they develop and how they're treated, so you can apply it and read the chapter. And but it doesn't make sense, in my opinion, to try to memorize stuff that you're going to see once every 10 years. You probably aren't going to remember it, and it's just not practical. So I want to also focus on the common ones, the ones that I have found to be the top 12. So first, this is an overview of the class. We'll go over definition and pathophysiology of trigger points, and the understanding of them from a Chinese medicine perspective, and treatment strategy for common trigger points. So it was started in the 19th century by Dr. Balfour and Fraureich and Strauss, and they described pressure-sensitive, painful knots in muscles. Then in 42, Dr. Janet Travell proposed the term myofascial trigger point. These are pictures of Janet Travell. As most of you probably know, her claim to fame was she was the first female White House physician, and she was credited with helping JFK. And at least one place I read that he would not have been able to run for president if it wasn't for her treatment. He had, as you know, low back pain, and she was able to help him. So that's what I just talked about. He had chronic pain, and yeah, I went over all that. So Travell was the first to propose the term trigger point, as I mentioned, in 42. Other things, she believed that patients who presented with trigger points or points, as well as their typical referral or autonomic reactions, had real conditions. This was during a time when, if a pain pattern didn't show up with visible changes in the MRI or other neuroimaging, et cetera, the patient was usually labeled as a malingerer and someone who's motivated by secondary gain. And she didn't buy into that, and she entered into the world of the patient and took their pain took their pain seriously rather, and then measured or mapped out the trigger point model. And there's still some tendency today to disregard patients if the neuroimaging comes back negative, but it's not as bad as it was in her time, and hopefully it'll keep improving. So she also talked about the role of low functioning of the thyroid gland in perpetuating and predisposing patients to trigger points. And it's still radical today to talk about alternate theories of the thyroid, but it was, again, more radical back then. So she was definitely ahead of her time, in my opinion. And let's see. So Travell's definition of a trigger point: a focus of hyperirritability in a tissue that, when compressed, is locally tender, and if sufficiently hypersensitive, gives rise to referred pain and tenderness, and sometimes to referred autonomic phenomena like vasoconstriction, sweating, lacrimation, pilomotor activity, also known as goosebumps, and distortion of proprioception. These aren't super common, but they do happen. The larger perspective, it should be noted that while skeletal muscles are the best studied in the context of trigger points, she observed other types of tissues like bones, fascia, ligaments, etc., can also have trigger points. So these so far have not been rigorously studied, as far as I know. In the case of bones, for example, it would be unethical to try and activate trigger points in the bones. You'd have to be like a Dr. Mengele or something to inject people in the bones, and you couldn't get people to participate. Skeletal muscles, on the other hand, can be loaded up with hypertonic saline, which irritates the muscles and triggers the referral or other pattern. And then it leaves the body, I don't know, an hour or two. So it's easier and more ethical to do this. In my experience, I believe I found some trigger points in soft tissue that aren't skeletal muscle. And in my experience, they don't seem to refer very far. It's estimated that skeletal muscle trigger points account for about a third of pain visits. And the few times I have hit a tendon, ligament, et cetera, the patient occasionally reports a referral pattern. But again, I have not seen any of them travel more than 4 to 6 inches. And I wouldn't be shocked if they're there. I just haven't found them. There is more than 600 skeletal muscles in the human body. And Travell and Simon's manual, there's at least 125 skeletal muscles. I think it's 126, something like that. And they have trigger point patterns. And some muscles have 4 to 8 trigger points. Some muscles only have 1, some have 2. But in the end, it creates a situation where there's more trigger points than you have time to study. And again, it's not practical to study something that you see, once a decade or something. Despite this, depending on one's practice, there's at least a certain number of common trigger points. For example, 85%, probably 90% more of the time, patients come with the common trigger points. And so again, we'll cover what I consider to be the top 12. Travell doesn't, well, she said, but she didn't look at it that way. But obviously there's some clinical bias. Like if you specialize in treating runners, you're going to see a lot of the trigger points below the knee. And in Boulder County, where I practice, we have a lot of climbers, and so we see a lot of shoulder stuff. And so obviously, if you have a different group of patients, you're probably going to see different ones. So, but what makes sense is for me to cover the ones that I see commonly. So that's what I'll do. So the most common symptoms from myofascial trigger points is pain by far, probably 90, 95%. Sometimes the pain travels to an area, and sometimes the pain stays on the injured muscle. Sometimes it doesn't go anywhere, just local. The most common muscle that can refer autonomic phenomena is the sternocleidomastoid, probably because of its proximity to the brain. I don't know if anybody knows. The associated autonomic phenomena such as sweating, abnormal tearing, abnormal salivation, increased vasomotor response, increased pilomotor response can also potentially occur in extreme cases of myofascial pain syndrome. It is believed that an autonomic phenomena is a result of multiple sensitive nociceptors located in the region of trigger points. Nociceptors are activated upon compression of a trigger point, which can potentially overstimulate sensory neurons. Other associated neurological symptoms include paresthesias, numbness, blurred vision, trembling, dizziness, and tinnitus. So yeah, most trigger points refer pain, and usually the quality of the pain for trigger points is deep, dull, and achy. And I always ask patients when they're talking about pain, what's the quality? And make sure they understand I'm not asking like on a 1 to 10 scale, I'm asking the quality. So if it's deep, dull, achy, it tends to be muscle. If it's sharp and burning, it tends to be nerve. And usually nerve pain is very easy to locate. You step on a tack or you get stung by a bee, you know exactly where that is. Whereas muscle pain is often kind of fuzzy. People will say, yeah, it's over there. And you go there and they're like, man, that's not really it. And then you go an inch higher or an inch to the left or the right or something. And then they're like, oh, that's it. And, but the way people experience it isn't as easy to locate as nerve pain. Please stop me if anybody has any questions or anything. I'll check the question thing soon. So again, the sternocleidomastoid contains the trigger points that are the most common to cause autonomic phenomena. The SCM and the clavicular division can trigger spatial disorientation. Patients complain of postural dizziness and less often of vertigo. So with the postural dizziness, a lot of times it's like when they go to lay back at night or engage the muscle with life activities. And then if that leads to postural dizziness, it could be from the SCM. Dizziness generally describes being off balance, and you might feel like you're going to fall. Many people with vertigo will report dizziness as a symptom. However, vertigo actually describes a specific type of sensation. Vertigo is when you feel as if your surroundings are moving. If you experience vertigo, you may feel spinning, whirling, or tipping like dizziness. Vertigo also impacts balance. Not uncommon for someone with vertigo to also experience nausea or vomiting. So the sternocleidomastoid sternal division concomitants include symptoms such as excessive lacrimation, tearing, reddening of the conjunctiva, apparent ptosis, narrowing of the palpebral fissure with normal pupillary size and reactions, and visual disturbances. These can include blurring of vision and dimming of perceived light intensity. In Travell's experience, unilateral deafness in a few patients with no complaint of tinnitus has been traced to trigger points in the sternocleidomastoid. I've never seen that, but I've read about it. The clavicular division of the sternocleidomastoid can travel to the ear and cross the forehead with its pain referral, which is very unusual for trigger points. As far as I know, the clavicular division of the sternocleidomastoid is the only muscle that can cross over. Ren midline muscles usually don't cross over except for that one. Chronic pain, most common cause of disability, annual cost greater than 650 billion, and the economic costs associated with chronic pain outpace combined costs from diabetes, cancer, and heart disease. It's estimated that about a third of visits to MDs are for pain, and about a third of those tend to be trigger point related. As far as I know, there's no studies as far as what people seek out acupuncture for. If you treat pain in your practice, it's probably a safe bet to say a third of it is trigger point pain. So it's not the majority, but it's a significant third. If you don't treat, that third well, then that's unfortunate for the patients, and it's not that hard to diagnose them and treat them. And then again, knowing the principles is key. So some people, if you look at the studies and the trigger points, they'll say a lot of times it would be something like, we took 120 participants in the study, we injected them in some muscle with hypertonic saline, and usually it says something like 96% of them went to where they usually go to if they travel, and then they'll say like 1 or 2 did something weird, and you do see some biological variability. I had a lady in a month or 2 ago, and when I applied pressure on her, it was her glute medius or minimus, she felt it go up to like the 12th rib, which is very unusual. I've never seen that before. And so sometimes they don't follow the rules. They just refer, I call it biological variability. I don't know why I've seen it happen, and I guess everybody's different, so maybe that's it. For chronic, pretty much anything, if it lasts more than 6 months, it's considered chronic. So it's important with the initial intake to take a detailed interview. There's in the second edition of Travell's book, there's pictures of a human, and you can make photocopies of those and have patients fill them out. The rationale for getting a good diagnosis or a good description of the pain is humans have a tendency to, if things are out of sight, they're out of mind, the saying goes. And so I always use the example like the thumbtack theory of pain. If you're sitting on 10 thumbtacks and you go see the chiropractor and she takes out 5 of them and you sit down, it's like, wow, that's 50% better. But then a week down the road, sitting on 5 thumbtacks is very annoying. And you tend to forget that it used to be 10. And it's the same. I've had people, at the 6-week mark say, I don't think acupuncture is doing anything. I don't feel any different. And then I'm like, okay. And then I get out the initial intake, and then they're like, oh, that's right. That used to happen, a lot, and it's not happening anymore. And it's just human nature. Part of it is with chronic pain, especially, it's a little bit like watching the grafts grow. Every day you're like, this isn't doing much. And you go away for a month or 2 and come back and it's like, oh, it's really grown. And it's similar with pain. So sometimes a pain journal is helpful. What you can do, again, is a detailed intake. So trigger point pain, again, tends to be deep, dull, and achy. Nerve pain tends to be sharp and burning. The only exception I'm aware of is the quadratus lumborum or QL. Sometimes that's lancinating, like a seizing kind of pain. And then, yeah, as you can guess, it's not uncommon to see damage to nerve roots, radiculopathy, together with myofascial trigger points. For quadratus lumborum trigger points, you often hear stories of how the patient had to crawl to the bathroom and how coughing or sneezing cannot happen unless the patient braces themselves. QL pain is usually deep and aching, but it may be lancinating again. Travell gives a case of a woman who was at a stovetop and she got QL spasms so bad she fell on the floor, and someone apparently came home and turned the stovetop off. And she lived to tell the tale, but she gives that example, or she gave that example so that you can see how severe some trigger points can be. Yeah, we tend to think, that muscle, it's only muscle, it can't be that bad, but it's not true. Muscle can be really intense. And we also tend to think the bigger the muscle, the more likely it'll cause pain. And that's not true either. Travell talked about that. Sometimes little muscles cause a lot of pain and big muscles less pain. And so you can't use that as criteria. QL pain, let's see. So yeah, I've had some people that come in with their partner, their friend, to the clinic, and they've got their arm around their partner or friend because they have real trouble getting around. So apropos of all muscles, so this is in the second edition. Let me talk about the books a little bit first. So this second edition is still available. It's in 2 volumes, an upper body and a lower body. And then there's a third edition, which is relatively new, probably a couple of years old at this point. The third edition has more research in it. And I started with the second edition, and I prefer the second edition. It has some perks that I haven't found in the third edition, but I have both. So if you're really into trigger points, I recommend getting both. The second one I think is a little more clinically useful, but I don't know if other people look at it that way or not. So skeletal muscle is the largest single organ of the human body, counts for 40% or more of body weight, yet the muscles receive little attention in medical schools, textbooks. We're much more interested in the bones, the joints, the bursa, the nerves. And if we can't find any problem on x-ray, there's a tendency not to take the pain seriously, although that's a little better than it used to be. But while this tendency to focus on neuroimaging, it's still present in Travell's time. This was even more the case. She and her colleagues were one of the first medical doctors to enter into the world of the patient and take their pain seriously. Overview. So diagnosing, in my opinion, it's probably 90% or more of the challenge. You explain the nature of trigger points, which we'll go over, and they identify with a referral area. You can show them the book and they're like, oh, that's my pain pattern. And patients really appreciate it, that somebody actually listens to them and finds their pain pattern. Some patients have been to 10 or multiple other practitioners, sometimes even PTs, although PTs are using the trigger point books more lately, but sometimes people don't use them. And if you don't use them, obviously you aren't going to know they exist. And so patients appreciate it when you take an interest in what's going on with them and you show them that they're not the only one, basically. And then also by differentiating which trigger point it is, you also differentiate the stretch. You can tell them what stretch to do. We'll go over stretches in detail, but getting the patient on board with the stretching is really important. And even if your acupuncture is subpar, the patient's going to get better by doing the stretches. If you diagnose it right and get them doing the stretches, I mean, obviously it helps. They get better faster if your acupuncture is appropriate, but they're going to get better if they do the right stretch and if it's diagnosed. So we're I think more effective as a coach in this situation. Oftentimes they're very grateful. Again, they've often seen other practitioners and nobody figured out the trigger point part. Clinical characteristics of trigger points. Myofascial pain is referred from trigger points in specific patterns. A trigger point will often go from like A, where the generation of the pain is, to B, where the pain it travels to. Sometimes, again, it doesn't travel. And then sometimes instead of traveling, it sets off, or sometimes it's both. Sometimes it refers pain and sets off, but they call them in the second edition satellite trigger points. So again, A goes to B, goes to C, and so on. I had lunch with a physical therapist friend of mine, and we were talking about trigger points, and he said he basically spends his whole day undoing chains. And I think that's accurate. If you study trigger points, again, you get A goes to B, goes to C, and so on. So trigger points can be directly activated: acute overload, car accident, probably the most common, overwork, fatigue. So using like being a cashier, using your arms too much, stuff like that. The direct trauma, shortening and chilling, also doing things that you're not used to. Like one patient in my practice I saw yesterday who she started some swim exercise that she wasn't used to, and it resulted in a trigger point. And or more commonly, people like shoveling snow, and they either use muscles that they don't use all the time, or sometimes they overload it, or helping someone move, especially if you and a friend are carrying a big couch and he or she slips a little bit, and you got to like keep, your instinct is to keep the couch from falling, and sometimes that will engage muscles that you're not used to. And then chilling, so like wearing a damp bathing suit, and sun goes down and it gets cold, that can set off trigger points. Viruses can also set off trigger points, and so a lot of things can set them off. They can be indirectly activated by visceral disease, arthritic joints, and emotional stress. They can vary from hour to hour, day to day. It may be increased from latent to active by many factors. The amount of stress needed to activate a latent trigger point depends on many factors, including the degree of conditioning of the muscle. The greater the exercise tolerance of the muscle, the lower the susceptibility of its trigger points to activation. So this sometimes acupuncturists butt heads with PTs, with patients hearing conflicting strategies. And sometimes some PTs, I think it's because they make money by having their patients lift weights. I don't know. Some PTs are like, you need to strengthen that muscle. And in my experience and what I've read in Travell is you have to eliminate trigger points before a muscle can be strengthened. And so that's my opinion. The signs and symptoms usually long outlast precipitating event. I had one patient who had chronic back pain over 30 years, and it was a trigger point, and it responded well, meaning no pain. And after I diagnosed it and treated it. And then on the other side, Travell talks about this. It's very rare, but some people develop trigger points, and she called them histological, which basically means tissue changes that result in myeloglosis, which is a term I've talked to a couple of MDs in the States, and apparently it's not used in the States, but MDs in Europe refer to it. It's in homotoxicology, which is a branch of homeopathic medicine. And basically, Travell had some patients and they did not respond, and she took a biopsy and looked at what was going on at the trigger point under a microscope, and she didn't understand it. She just knew it was like a myeloglosis, like some kind of gelatin, and it made people non-treatable. She was again, she didn't understand it. So there's a book by P.E. Baldry called Acupuncture, Trigger Points, and Musculoskeletal Pain. there's some good stuff in there. He talks about secondary activation of trigger points, satellite trigger points. Intriguingly, they follow the meridians. He thought that basically the Chinese acutracks coincide with the trigger point pathways, and a lot of them do follow the meridians. Maybe all of them. I haven't really thought about it. Acutracks used in China for anesthesia, according to Baldry, seems more likely these are propagated sensation that owe their existence to some as yet unidentified activity in the central nervous system. Yeah, my best guess is meridians and trigger points exist in the brain. I think acupuncture is brain therapy. I mean, obviously it treats the body too, but I think there's a piece of the brain that is treated with acupuncture, and it connects with trigger point theory. They're not anatomical structures. They may exist as some form of electrical energy in the central nervous system, according to Baldry. 71% Meltsack and colleagues who wrote a big book on pain, they believe there was a 71% degree of correspondence between trigger points and acupoints. And it's now realized musculoskeletal pain does not necessarily originate at the site where it's felt, but it's inferred there via the central nervous system from some focus of neural hyperactivity, now known as a trigger point, that's often situated some distance away. So trigger point, the phenomena basically describes something similar to holding a gun and pointing at the wall, and then you pull on the trigger and boom, there's a hole in the wall. And so it's similar. The skeletal muscle will have a trigger area, and then in many cases, the pain travels. Again, sometimes it doesn't travel, and sometimes it sets off autonomic phenomena. But the trigger piece is an important part of the manifestation. Applying pressure on a trigger point often results in the perception of pain at a distant location. A lot of times people say, oh, that goes to my headache, or that goes to where my back pain is, or something like that. Some trigger points do not refer pain, like satellite trigger points. Instead, some trigger points manifest with local pain, like levator scapula. Some muscles, when active, trigger autonomic phenomena, most notably the sternocleidomastoid. So the anatomy of sarcomeres, I don't know, maybe you guys remember biology. This slide didn't come out well. There's sliding filaments with skeletal muscles, actin, myosin filaments, and it's like a ratchet kind of thing. They like if you contract your bicep, they slide together. If you extend it, they go apart. And trigger points are basically blood stasis in these actin myosin filaments. Travell in second edition, there's some mention of radioactive isotope studies where they infuse the tissue with radioactive isotopes. And as you know, every cell has a yin and a yang. And in one way to look at it, every cell has to have oxygen and nutrients coming in, and it has to have waste products going out. And obviously, if that was totally compromised, the tissue would necrose, and so it's not totally compromised, but it's partially compromised. So the circulation is impaired, and the Chinese figured this out a long time ago, that basically something's stuck, and that's the essence of a trigger point. So blood stasis in skeletal muscles generally corresponds to trigger points. ATP, maybe Qi, gets stuck in the actin myosin contractures. If you hit the epicenter of the trigger point with a needle of any type, it will usually produce a localized twitch response, or LTR. The research shows that if there is an LTR, the outcome is better, meaning less pain. Some of these twitches will be palpable and visible, like the TRAP number 2, is roughly gallbladder 21 area. Others are not palpable and or visible, or less so, such as the piriformis trigger points. And therefore, effective, successful patient communication is key, as your patient can inform you if you successfully hit the trigger point and it twitches. And so communication is really important, and there's several reasons I'll go over. In Chinese medicine, the saying you've heard, I'm sure, Tongzhi, Butong, Butong, Zhitong, where there's free flow, there's no pain. Where there's pain, there's no free flow. Pretty simple concept, but profound. Basically, the Chinese figured out the relationship between stasis and pain a long time ago. And Western studies of trigger points show that blood stagnation in sarcomeres creates trigger points. all cells have the yin yang of healthy components like oxygen, nutrients entering, and waste products leaving. I mentioned in trigger point, this yin yang function is impaired. So the iceberg analogy in this situation, there's active trigger points and latent trigger points. So you can think of active trigger points. If you think of the surface of the water as like the surface of consciousness, and then an active trigger point is one that patients feel, and that can be considered like the top part of the iceberg. And then the latent trigger point is the part that's hidden from consciousness. And so again, active versus latent. Active trigger point defined as myofascial trigger point that causes a clinical pain complaint. It's always tender, prevents full lengthening of the muscle. So yeah, some of the muscles like subscapularis, it will cause shortening. As you know, subscap is like your volleyball spiking muscle, your raise your hand in classroom, ask a question muscle. And when that develops trigger points, like all skeletal muscles with trigger points, they shorten. And so that one, people will go to raise their hand, they'll say, oh, I can only go halfway and it hurts. And you can't test every muscle with range of motion, but some of them you can. So it weakens the muscle, refers a patient recognized pain on direct compression, mediates an LTR when it's stimulated properly, and when it's compressed, usually causes the patient's pain pattern, and sometimes autonomic or satellite trigger point stuff. Latent trigger points are defined as myofascial trigger point that's clinically quiescent with respect to spontaneous pain. It is painful only when palpated. Latent trigger points not only cause pain with compression, but can also cause autonomic phenomena, and they restrict the range of motion of the affected muscle. So the brain connection, so like the question, if a tree falls in the woods and no one's there to hear it, does it make a noise? Trigger points do not occur in a vacuum, they occur in a person. So in other words, to exist, they have to be perceived by a person. And, some people are much more sensitive to pain and trigger points than others. And nobody really knows why. In the same way that different people have different sensitivities to pain, different people have different sensitivities to the symptoms of trigger points. They're far more common in people with fibromyalgia than they are amongst the general population. The prior method for diagnosing fibromyalgia was 11 out of 18 trigger points, and now it's different. But fibromyalgia is more and more accepted as a diagnosis. My only complaint about the use of fibromyalgia tends to be a trash can diagnosis. It's like, oh, somebody has pain that we don't understand, let's call it fibromyalgia. So it tends to be put everybody in this category, and I guess it's better than no category. So the main symptoms and signs: fatigue, lack of energy, trouble sleeping, depression, memory problems, trouble concentrating, sometimes called fibrofog, headaches, muscle twitches or cramps, numbness or tingling in the hands and feet. You can see how pain of any type tends to damage the qi of the zongfu. So like any stressor, pain will cause the qi to stagnate and the organs to become depleted. In some cases, central sensitization makes the patient significantly more sensitive than the average person. Alterations in perception can play a significant role in this. The brain connection, again, central sensitization is the concept. It's considered by many experts to be a key behind fibro. Central sensitization may also be involved in certain aspects of chronic fatigue, helps explain many of the symptoms of these illnesses, including the way the body and brain amplifies pain signals. First, let's see, the importance of understanding pain receptors, a trauma response in establishing effective communication with the patient. First, the anatomy of the pain receptors. So research shows the fingertips and forehead are the most sensitive to pain. Basically, there's more nerve endings there. And in many areas where there's trigger points, there are relatively not a lot of pain receptors. Just like with acupuncture, if you hit one dead center, it's going to hurt. And the only antidote is take the needle out and put it next to it. It's not likely you're going to hit two in a row. I studied mostly Japanese style acupuncture, and so trigger point needling was different for me because it was way more aggressive than what I generally like to do. And so it took a while for me to play around with trigger points. And part of what got me into it was understanding that it's really not that painful for the majority of patients. And part of it is because the pain receptors are scattered out, like in the gallbladder 21, Jianjing area. They're kind of like landmines that are thrown haphazardly around. And if you hit one, again, it's going to hurt. But if you don't hit one, they won't feel it. And once you're through the skin, it's possible that you hit some kind of sensory pain receptor, but it's less likely. And so when you look at it from the outside, it looks like, wow, that's going to be really traumatic and be hard on the patient. But when you actually do it, patients usually don't complain, and it's not that painful. If it was really painful, I probably wouldn't be a fan of it. So needling trigger points can be significantly more aggressive than certain styles of needling, especially Japanese styles. It's possible without traumatizing the patient, as long as the practitioner establishes good communication. So understanding the trauma response. So as you know, there's a fight or flight, which is well known. There's also freeze. And so sometimes patients space out, or PTSD patients space out. And so as a practitioner, it's your responsibility to make sure they're breathing normally. And if you think they're spacing out, just ask them a question and say, is this tender? Can you feel this? And kind of drag them back into awareness. But communication, again, I always tell patients they have veto power. If anything hurts, I don't want to cause pain. It's probably a disadvantage causing pain. And so if anything hurts, tell me. I won't know unless you tell me. And if it hurts, again, just pull the needle out, go somewhere else. And you'll be surprised, if you haven't done trigger point needling, you'll be surprised at how much you can do without patients feeling pain. So explain to the patient the nature of a local twitch response. I hold my fingers together like this and talk about the actin-myosin filaments, and that they shorten and blood gets stuck in them. And then they understand. I think it's important to get the patient on board, and so they if they understand that they are more likely to be a full participant. And again, giving them veto power. So trauma is really about having control taken from you. Whether someone is raped or some other you're mugged or whatever causes trauma. And the opposite is true. I figured this out with, I had a patient who, her husband killed himself, Medicare fraud. He was embarrassed, and anyhow, she was depressed and she wanted to quit smoking, and she wanted to do acupuncture for smoking. The only problem was she, when she was in junior high, somebody attacked her with a knife. So she had PTSD about sharp, pointy objects. And so she wanted me to do acupuncture, but she didn't like sharp, pointy objects. And I was like, okay. So I figured out how to do it. Basically, I'd say, okay, when you're ready, I told her, first of all, I'm not going to do anything unless you tell me it's okay. And so I said, okay, when you're ready, I'll come sit next to your ear. That's it. And so she, whatever, half a minute, she said, okay, come sit next to my ear. And I said, okay, when you're ready, I'll open up the needle package. And so we did that, and basically put her in charge of all of it. And we got away with sticking needles in her ear. And I think if I had come in with the attitude, it's like, I'm the acupuncturist and you're the patient, shut up. And I don't think it would have gone over that well. And so working with someone who had a definite PTSD history helped me understand that giving the patient control is really the best thing we can do to make it less traumatic. And so often the fight or flight stage of trauma is understood. I talked about some people space out. Another important part about trauma, the control, I think we talked about that. So the importance of understanding pain receptors. The other extremely important reason you want to have clear communication with your patient is because with deeper trigger points like glute minimus, for example, you won't be able to feel it or see it. And so the only way you'll know is if the patient says it twitched. And so, or if maybe they'll say it didn't twitch. And so if it twitched, that means you're in the right area. You want to hang out there. If it didn't twitch, that means you need to keep looking. Once in a while, patients will say, oh, it feels like it wants to twitch. And think it's a combination of stasis and deficiency usually, and some trigger points give up the twitches more readily than others, and I think it has to do with the constitution, also the chronicity. As you would guess, with more chronicity, there's usually more blood stasis. So, and getting the patient on board and getting their feedback is crucial. Again, and so like certain points like gallbladder 21 or trap number 2, you will see it and you will feel it. It'll twitch, it'll fasciculate. And so that one, communication isn't important to know whether it twitched or not, but to know whether it hurt or not, that is important. And again, deeper ones in the hip often are not visible. Usually they're not visible. And so getting the patient to communicate is key. Then there's perpetuating or predisposing factors. These are in Travell's book, they're commonly overlooked and neglected. Actually, this is covered in the second and third editions. Never had the first edition, but it's probably in that one too. In patients with trigger point pain, attention to perpetuating or predisposing factors often spells the difference between successful and failed therapy. Same factors that perpetuate trigger points will also predispose. So you get two people in the same car wreck, and one has horrible posture and maybe low thyroid or something else, and they end up with a lot of symptoms. And the person whose health is really good may walk out scot-free, even though the vectors and the collision forces, they're all the same. So the perpetuating factors, Travell basically said if a trigger point, if a pain pattern goes away for a couple hours, it's almost always trigger point. And then if it comes back, it's almost always a perpetuating factor. And so some people say, oh, I'm bored. I don't like treating pain. It's boring. And I think if you look for the perpetuating factors, it basically requires you to put on your Sherlock Holmes cap and try and figure out, what's going on in the big picture. And so I don't see it as boring. I think it's interesting. So these also predispose people, again, as I mentioned, in the car accident analogy. So then there's mechanical stressors, skeletal asymmetry, such as lower leg length inequality, LLI. A small amount of lower leg length inequality can be critical. And Travell talked about this, like if you might have, say, a 0.5 centimeter difference in leg length, and maybe you're doing great, and then boom, you get in a car wreck, and then all of a sudden, if say the quadratus lumborum was affected, and then all of a sudden that discrepancy in length will make it more challenging for that muscle pattern to get better. So it's one of those things, I guess, like straws on a camel's back. Something tips it over, and then it becomes crucial. But some people can get away with it if they don't have any trauma. And then small hemipelvis can also, and she also talked about Morton foot structure or configuration. I don't use that. And then short upper arms, the tips of the elbow should go to your ilium. And some people have short upper arms. I'm ironically a fan of the NFL, and I don't know if you guys follow football at all, but a lot of times, like the left tackles, or I guess tackles in general, they describe their physique and they use T-Rex analogies. As T-Rex, a big body and small upper arms, and but yeah, sometimes people genetically, their upper arms are small. Poor posture, probably all of us are contributing to that now. Sitting at the computer, repetitive motion injuries, I mentioned. Nutritional inadequacies can perpetuate trigger points, B1, B6, B12, and or folic acid. So again, if something only responds for a couple hours and it comes back, then you got to figure out why. Other things, iron deficiency, anemia, parasites, allergies can perpetuate. And then in the third edition, they came up with a couple new ones. I think it's like estrogen and I think testosterone. So again, the third edition is helpful for updated research and more research. So metabolic endocrine factors. So again, Travell was open to suboptimal thyroid function. It's still controversial today, although less so than it was back then. But and then hyperuricemia and hypoglycemia also can perpetuate them. I had one patient who she was a photographer, and most people, when they hold stress in their body, they'll like grind their teeth at night. And there's a small group of people that tighten their arms, and she was one of them. And so when she slept, she had to wear braces because her arms, her unconscious mind just got her arms all tight. And anyhow, we treated some arm trigger point. It got about 50% better. And it's like, we're missing something. I don't know why this isn't getting all the way better. So I referred her to an MD I used to work with, and he got her, well, actually, I had her do oral temperature that MD I used to work with used to use. I think it was 97.6 and lower. If their oral temperature was 97.6 or lower, then they were candidates for armor thyroid. Different people have different opinions on it. But anyhow, once she got on armor thyroid, her body temperature, she was like 94.8. I mean, she wasn't room temperature, but she was cold. And anyhow, once I sent her to this doctor who got her on armor thyroid, then her arm stuff got better. And so, again, figuring out the perpetuating factors makes pain treatment more interesting, in my opinion. And then let's see, herpes simplex virus type 1 is a common source of increased susceptibility. It can aggravate trigger points, especially like levator scap and some of the upper neck ones, which is interesting. Other things can perpetuate them: infestations, tapeworms, giardia. Psychological factors: depression, tension caused by anxiety, others. And then allergies, impaired sleep, radiculopathy, chronic visceral disease, plus nerve impingement. So in the third edition, they add gonadal hormones, so estrogen, and I believe it was testosterone as well. You can read that over. So there's a concept of somato-visceral versus viscerosomatic. So as you know, soma refers to the musculoskeletal body, and in this case, visceral refers to the organs. So probably the most common example of a viscerosomatic, so viscero again, or we're talking about organ to skeletal body. The most common example that we see and are aware of is when a woman of menstruating years gets her cycle, and then this triggers low back pain. So specifically, the smooth muscle of the uterus is spasming, and energetically it's connected with low back muscles. And so the spasming of the smooth muscle of the uterus then makes the low back muscles cranky. And so that's the most common that I know of viscerosomatic example. So somatovisceral, actually, let me give you another viscerosomatic. So another example for men, at least, heart attacks. So with myocardial infarction, the heart part of it dies. I mean, obviously, if too much of it dies, game over. But if a part of it dies and the patient lives, then as you know, the heart is a smooth muscle, and it can make pec major cranky. And one of the referral patterns pec major has is the classic male heart attack problem, going down heart and small intestine channel, basically. So that's another example. So somatovisceral, where it goes the other way. So there is a trigger point in the pec major that can trigger arrhythmias. I only saw it once, that this woman, they had her on a Holter monitor, an EKG, blah, 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 a ridiculous amount of testing. And then they're like, oh, you don't have anything wrong. And then we got the book out, and sure enough, it was a pec major trigger point, and I treated it, and the arrhythmias went away. So in this case, skeletal muscle of the chest triggers arrhythmias, and the smooth muscles of the heart. Probably the most common muscles that reflect strongly in the organs are the abdominal muscles. So yeah, there's a big interplay between, like your gut, your small intestine, large intestine, stomach, and the rectus abdominis. And so they, if the organ has trouble, it can make the abdominal muscles cranky. And then it becomes, they tend to feed into each other. There's other examples, dysmenorrhea, prostate problems, etc., digestive disorders. So another common example of this energetic interplay is the relationship between the abdominal muscles, such as rectus abdominis, with internal organ. So McBurney's point, as you know, is reflects inflammation of the appendix, and that's in the rectus abdominis. The other abdominal muscles can also be involved. They're capable of initiating somato-visceral responses, including projectile vomiting, I haven't seen that one, anorexia, and nausea, intestinal colic, diarrhea, dysmenorrhea, etc. So the X's, in the diagrams we'll go over, they have X's, and I heard from a couple sources that Dr. Travell didn't want the X's to be there, and that she wanted people to develop their palpatory skills. And then in the third edition, they don't have X's, and they basically say the trigger points can happen anywhere in the muscles. And while I agree that's true, they do have a tendency to be where the X's are. So I consider the X's kind of like acupuncture points. It's like gets you in the right area, but then if you want to find the exact area, you need to palpate. And some people like the X's, some people don't. In the third edition, there's no X's again, and again, palpatory skills. So one of the important things for palpatory skills, which I always tell people studying trigger points or acupuncture in general, is you want to learn how to what it feels like when you palpate blood stasis. And the best way to understand it is to palpate people that don't have blood stasis. So palpate a healthy person, like a healthy meridian or healthy abdomen or whatever you're going to palpate, and then palpate an unhealthy one, and try to make make a cognitive difference. Basically, with like they talk about in shiatsu or ischemic compression, when you apply pressure, all the blood should scatter away in a healthy person, and then when you relieve the pressure, it should gradually come back. And when there's stagnation, that doesn't really happen. When you push, it's kind of like an energetic thud. It's like the stuff doesn't move. The blood doesn't move as well as it normally does. And it's a skill that you've already acquired. If not, it's not that hard. Some people are more tactily gifted than others. So maybe some people will take a little longer, some people will take a little less. It's something you can learn if you don't know it. So I really recommend that you learn that, again, for acupuncture and for trigger point diagnosis especially. So the tenderness trumps the anatomical location. I think Olson wrote in his book on auriculotherapy, the map is not the territory, or maybe someone else said that. The territory is the territory. The map is the map, and it has its place, but don't confuse the map for the territory. So asymmetry, trying to keep track of the time so we take a break on time. So Travell talked about 90% of humans are asymmetrical. And so Rachel Maddow is the person that always comes to mind with asymmetry for me. So if you look at the corner of her mouth, and then like Sanja 23. So in Ms. Maddow's case, if you draw, or if you hold your finger from the mouth to the eye on one side, it's quite shorter. Her right side is quite shorter than her left side. And usually when this happens, it's not just the face, it's like the hemipelvis and the lower leg length. Usually one side is more yin and one side is more yang, or more prone to imbalance. And so you can look at the face for clues, and then you can have them sit and palpate their the crest of their iliums and look for difference there. And you can palpate like the medial or lateral malleolus and look for lower leg length inequality as well. So according to Travell and colleagues, again, 90% are asymmetrical, measure between the corner of the mouth and the eyebrows. In the case of Ms. Maddow, there's a clear difference. Talked about this. Usually that's the smaller side. what I just talked about, lower leg length inequality. So yeah, the muscle that really gets cranky with lower leg length inequality is quadratus lumborum. So anything that, if they genetically have a lower leg length inequality, that's going to be their Achilles heel, low back pattern. And then anything that creates it artificially, like one of the best ways to set off your QL is go jogging on the side of a road where there's an incline, and so one leg is shorter than the other based on the territory, or on the side of a beach works too. And so the body, it wants to stay in a plumb line, just like in carpentry. It wants to be at a 90-degree plumb line, and it does it, but it does it by engaging the QL, or the quadratus lumborum muscles. And so those muscles get fatigued. And so if something tips the pelvis, the QL compensates to keep us on a 90-degree angle, like a plumb line. But it comes at a cost, especially if it's over time. You see it also like patients that are put in a boot. They break their leg or whatever, and they're in a boot for however long, and that will tip the pelvis. So it's fairly common. Let's see, okay, I covered this. Okay, general treatment strategy. So Dr. Seam, or Mark Seam, he's retired, is my understanding. He's got several books out. A couple of them talk about trigger points. And I liked his books on trigger points and pain. He points out that often early charts of acupuncture meridians look like they're in 2D, similar to Gumby. And so he asked, why? And one of the things he brings up is, is it because they didn't have the artistic ability to draw a detailed body? And he says, no, it just wasn't a priority. So according to Dr. Seam, palpation was key. The meridians and points are general locations to begin palpating, and the charts were often incomplete. As acupuncturists recognized that palpation was key in order to correctly locate points. So if detailed anatomy was valued, then the Chinese definitely had the artistic skills to demonstrate where the points were in relation to anatomy. So you see a very big difference, obviously, in the West and in China. So again, Dr. Seam's view is the Chinese it wasn't a priority because they assumed that the practitioner would have the palpatory skills to find the points. And the map was just like a general guideline. And he wrote in several books. He covers his use of trigger points with acupuncture and New American Acupuncture, Acupuncture Physical Medicine. So translation review, as you know, the terms meridians and points are inaccurate, but they've stuck. I use them, and I'm stuck using them. The character that gets translated as meridians, as you know, Jinglo or Keiraku in Japanese, it's more accurately translated as channels. The character that gets translated as points is more accurately translated as holes. And as I understand it, this started when the Dutch came to the East and looked at acupuncture charts, and they concluded that the pathways were akin to meridians on a globe, and the character shui was akin to like a city or a dot or a point on the globe. And so this poor translation stuck. And so again, rather than meridians and points, probably channels and holes are a better translation. I've seen some people refer to them as acu holes. Doesn't sound that great, but it's more accurate. So here's the example of like what Mark Seam talks about, a relatively simplistic chart of the meridians. And then Dr. Seam, again, he says the Chinese didn't lack talented artists. The following slide has some landscape photos, or landscape artwork rather. Dr. Seam argued that detailed anatomical view is just not a priority, as the use of palpation to find the points was prioritized. This many diagrams look like Gumby. So this all changed, like many things, with the PRC redesigning Chinese medicine, and they wanted to make it as scientific as possible. So they got into the this point is this many Tsun, or whatever, into more exact locations. But that wasn't always the case. The main point Dr. Seam is trying to make is that while the Chinese had the technical skill to draw the body with accurate anatomy, it was not a priority. And here's an example of Chinese landscape art. You can see the extreme detailed. If they were motivated to do a very detailed image of the body, they had the people to do it. And the contrast, this is Andreas Vesalius, 16th century, often called the father of anatomy. And so in the West, more detailed anatomy was a priority. So general treatment strategies, the wet needling versus dry needling. So as you know, it's a very political topic, and the dry needling, as far as I know, it started with Dr. Travell's work. Basically, she would inject she would inject procaine into trigger points. I forgot what strength, but she used procaine. And then she also experimented with injecting nothing, basically using a hypodermic needle and presumably a syringe and getting the twitch reaction. And according to her research, or her colleagues, I can't remember, somebody's research, it's in her second edition, dry needling causes more post-needling soreness. And so while, Motrin or, NSAIDs don't work for trigger points in general, if there's post-injection soreness, they do work for that, is what Travell discussed. And then, as you can guess, the dry needlers have come out with research showing that there is no significant post-needling soreness. So I guess it depends who you want to believe. According to Travell and her colleagues, dry needling tend to create more soreness. I talked about that. And she used procaine. So yeah, as you know, varies state by state, but currently PTs and others who do dry needling use the Travell books as their Bible. So what's the saying? Keep your friends close, but your enemies closer, something like that. And it's good to know what they're doing. And I've known a couple of people who've done the dry needling classes, and the few that I've known say that it's a different animal than, or different entity, whatever you want to call it, than what we do with acupuncture. And I've had some patients, you probably have too, that say, "Oh yeah, I did dry needling and it really helped." And my main beef with them is a lot of times they don't seem to understand the trauma response. I've had some patients that get traumatized by dry needlers, and and I'm not sure if that's the limitation in their training or something else. I don't know. But they help some people. Ischemic compression, basically this is shiatsu or tuina, it's called anfa pressure method. The hypoxia followed by reactive hyperemia. So one applies pressure to move the blood and chi away and then releases, allowing it to return. When blood stasis is palpable, again, there is a different feel to the application of pressure. So again, you push and it just doesn't move the way, and usually if it's a trigger point, it's tender. So spray and stretch using vapor-coolant sprays. This was the workhorse of Janet Travell's system. She talked about it a lot. And I think this is part of why her system relatively died out. Like it's rare to see trigger point classes. And as I talked about with the history, I'm self-trained, and there's some good parts and some limitations with that. Some stuff I just don't know that well because I didn't have a teacher. I think I've seen one trigger point workshop that was out of state in the last 30 years or something like that. And yeah, I think part of the reason is she did spray and stretch. And then even with the second edition, the awareness that the spray and stretch was damaging to the ozone layer was out. And so she recommended like using ice instead of spray and stretch. And I tried ice. I wasn't that impressed. So I think you had a person who is famous who developed a whole system that was very unique and like one doctor talked about she developed a system where there was nothing before, and then it died or relatively died. And I think because their main workhorse, all of a sudden they're like, oh, we can't use this because it damages the ozone layer. And now, as you may be aware, there are vapocoolant sprays that don't damage the ozone layer, but I think there was a 10 or 20 year period where that wasn't the case. And then, she died, she talks about, how to inject each muscle and about other therapies as well. But again, her workhorse was spray and stretch. And I think that's why it's not more prominent today. They provide transient anesthesia via aspiration. So yeah, the vapocoolant sprays, I forget how low they get the temperature of the skin, but really, really low. And so it numbs out. As you know, there's a gate control theory of pain or acupuncture. They're like only so much information can get in through the sensory neurons to the spine, to the brain. And so if you flood that with like vapocoolant spray, then like if you watch the videos of Travell towards the end of her life, there's videos of her doing trigger point work. And I think somebody realized she wasn't long for this world and got her on video. And anyhow, it's like watching your grandma do kung fu on someone. It's kind of bizarre. But she has them stretch out, sprays them, and goes in and manually works on the trigger points. And but yeah, if you freeze or any sensory information, I believe you can do it with liniments too, or some liniments. You can get away with more if you're flooding their sensory inputs. Ultrasound can work according to Travell, application of heat. So yeah, heat, I'll talk about the thermophore that I use a lot. The research shows moist heat helps the most. And so the shower, hot tub, anything like that, those rice packs you put in the microwave and heat up, that's relatively moist. And then strain, counter strain, or muscle energy technique, some people call it PNF, probably a bunch of other things. It basically, if you can't get a muscle to relax, then you get it to tighten up. My first yoga teacher was big on that. He would, after the yoga session, he'd have us lay on our back and he'd say, okay, tighten up your feet and then let them go. Tighten up your feet to your knees and let them go. Your feet to your knees to hips and let them go, or something like that. And it's basic yin and yang. If you can't get something to loosen up, you can get it to tighten up. And so you can use that on trigger points. I do it all the time. People actively try and push against my thumb or my elbow or whatever I'm applying pressure with, and hold it for a few seconds and then let go. And sometimes it is a deal changer. So the gate control theory of pain, I think I talked about this. It was her workhorse. She said over and over, stretch was the action while the spray was the distraction. Probably worked through the gate control theory. By rapidly freezing the skin, referral area around a trigger point. Oh, here they chill it to as low as minus 50 degrees Celsius, minus 60 Fahrenheit. In a similar manner, you can use icy hot, target bomb, etc., on certain muscles, especially like the anterior neck muscles, sternocleidomastoid, scalenes, etc. By flooding the sensory input with liniments, you're able to go into the anterior neck muscles and do deeper work, move more chi and blood, or show your patient first how their trigger point sets off their headache and teach them how to gently break it up. If for sternocleidomastoid headache patterns, I'll first is explaining, making sure the patient understands how their headache comes from their neck. And then the second is getting them or their partner to manually try to break up the chi and blood. And if they can do that on a daily basis, it's going to be a better outcome than if it's just you seeing them once or even twice a week. So general treatment strategies. So generally, I like local in the trigger point area. We'll talk about details, and then sometimes I hook it up with electrical stim. Sometimes I don't. And then some kind of distal. You can use 8 extraordinary vessels. You can use master tongue. You can use Mark Seam's system, Whitfield Reeves system. I've used that one. And then I like auricular. I'm a big fan of Dr. Huang, who I think she passed away last year. I really recommend her lectures on E-Lotus. I've had good results. I have no idea how it works, but I know it does work, and especially the bleeding. I've been really impressed with that. And again, she's got an 8-weekend series on E-Lotus, and they're loaded with very useful information. Then let's see, general strategies for myofascial pain. Terry Olson's, I like his book. I like Dr. Huang's books, and then Terry Olson's books. I wish that they had collaborated, because Dr. Olson mapped out the ear and shows like the hidden parts of the ear better than any Chinese or other book I've seen. And yet Dr. Huang has the substance and the content. Some of her maps I don't find that useful, but obviously they didn't work together. But I recommend them both. So it's 1/4 after. We're supposed to take a break for 10 or 15 minutes. Does that work for you, Donna?